I'm going to go ahead and introduce the next moderator of the local therapy section, and that is Dr. Lawrence Menendez. He is a full-time senior member of the Department of Orthopedic Surgery at the Keck Medical Center of USC, where he specializes in the management of malignant and benign tumors of bone and soft tissue. He is one of a handful of orthopedic oncologists in Southern California who's experienced in performing complicated limb-sparing surgeries, as well as other orthopedic cancer techniques such as cryosurgery and radiofrequency ablation. Primary musculoskeletal cancers are rare, and Dr. Menendez has treated a ton of these regularly since 1985. And thus he is highly experienced in this area. He uses a coordinated multidisciplinary approach with radiation oncology, medical oncology, nuclear medicine, radiology, surgical pathology, occupational and physical therapy, as well as social services and pain management. Over the years, he's developed a special interest in treatment of tumors of the pelvis and sacrum. Dr. Menendez joined the faculty back in 1985 after his fellowship, and he has been involved in clinical research for over 27 years and the author of numerous articles. He's been invited to speak at universities both in the United States and abroad. Dr. Menendez received his medical degree from New York University School of Medicine, where he was elected to the Alpha Omega Honor Society. He completed a fellowship in orthopedic oncology at the prestigious University of Florida Oncology Program under the guidance of an icon in orthopedic surgery, Dr. William Enneking. So please welcome Lawrence Menendez. Do you have any slides? No. Can you put up Dr. Tseng's slides?
So our first speaker is Dr. William Tseng, who went to medical school at Northwestern and then did his general surgery at UCSF, and then a fellowship in surgical oncology at MD Anderson Cancer Institute in Texas. And he's been on the faculty now for several years. He specializes in the treatment of soft tissue sarcomas. He is an active member of our multidisciplinary team, and he leads the retroperitoneal sarcoma surgery program. He's been very active in advancing the field of soft tissue sarcomas through research and collaborations. He's published extensively and won actually several awards for his research. He's specifically well recognized for his expertise in treating liposarcomas, and he's currently funded to develop immunotherapy as a treatment option for these patients. So I'd like to introduce him. And
well, thank you for that introduction, Dr. Menendez, and I wanted to thank Dr. Hu and Dr. Fryer for the opportunity to talk at this symposium. As Dr. Menendez mentioned, I'm a surgical oncologist here at USC, Associate Professor of Surgery. Just an outline of my talk, we're going to start off about what is soft tissue sarcoma. Just a few slides. I know we've already kind of covered this, but just to get everybody on the same page. And then I'll quickly go into the overall treatment of soft tissue sarcomas, the principles of surgery, and then unique considerations for the AYA population. So first of all, what is soft tissue sarcoma? Sarcoma does mean cancer of the flesh. It's divided into bone and soft tissue sarcomas. Bone sarcomas tend to occur mostly in children and adolescents. Soft tissue sarcomas mostly in adults, but there is some overlap, of course. My one disclaimer is that I am not an orthopedic surgeon. I'm general surgery trained, and so any bone sarcomas that I get, I send directly to Dr. Menendez. And that's the first disclaimer. Second disclaimer is I kind of have a headache. I'm getting over a cold, so apologize about that. Anyways, so I specialize in soft tissue sarcoma, and most of the patients I see are adults, but I see a fair number of patients that would be considered AYA. and AYA overlaps between the bone and the soft tissue sarcomas. So what is the soft tissue sarcoma? So these are rare cancers, as everybody in the room probably knows. They represent only 1% of, at least for adult cancers, are 1%. Accounts for about 10,000 to 12,000 cases per year in the United States. And that, by comparison with, say, breast cancer, has about 250,000 cases per year. They can occur anywhere in the body, which makes treatment challenging. They're most common in the extremities, the arms and the legs, but they can occur in the trunk and as well as the retroperitoneum, which is the abdomen, or specifically the back of the abdomen. As Dr. Hellman discussed extensively, this is a very heterogeneous group of cancers. There's over 50 to 70 histologic subtypes, and the more we understand the molecular underpinnings of this disease, we're finding that there are probably even more subtypes than that. In terms of clinically, so it's not just the molecular underpinnings, but clinically these subtypes do behave differently. One subtype of soft tissue sarcoma is not the same as the other, et cetera, et cetera. I've actually been able to publish an editorial where I made the analogy of soft tissue sarcomas to wine. There's many different subtypes, there are many subtleties and nuances to each of the different subtypes. It's a little bit like wine. And I always admit that I'm not an expert on wine myself. I don't know anything about wine, but I guess sarcoma is my wine, so to speak. Excuse me. So, treatment principles of surgery. Well, for localized disease, non-metastatic disease, surgery is the mainstay of treatment, just like in many other cancers. But chemotherapy or systemic therapy, radiation therapy play an important role. You'll hear a lot more about those other modalities of treatment with the talks that follow mine. And the main thing I wanted to point out with treatment of soft tissue sarcomas, as well as bone sarcomas, is that the key to treatment is that it's very collaborative. And that is a picture of a sarcoma tumor board. I'll have to admit also that is not ours. I just got that off of Google. But that's what ours looks like. And it is a collaboration between surgical, medical, radiation oncology, as well as radiology and pathology. All of us are specialized and focused in sarcoma. And so getting to specifically surgery for soft tissue sarcoma, and I'll focus on extremity, that's where it most commonly occurs. Historically, amputation was the standard treatment. When I say historically, that's probably about 20 years ago, maybe about 10 years ago. And that is, for the most part, historical, although that little asterisk is trying to say that we do still have to do amputation in some patients. So it's not, we avoid trying to do it, but there are still patients where it's indicated. Sometimes amputation can be even more extensive or fairly morbid. That's a forequarter amputation, that's a hindquarter amputation. Now, the standard of care is limb salvage, and what that really means is it's a combination of surgery, radiation therapy, and I would even say systemic therapy in some situations, basically multimodality therapy to try to salvage the limb. There's data, this is the original studies from the NCI that show that there's no difference in survival with amputation versus adequate limb salvage. And radiation plays a very important part of that, as shown by this study, by these two studies. So when you are trying to salvage the limb, there's always a question of how much do you need to get in terms of the margins. For a lot of cancers, for breast cancer, for colon cancer, the margins are very important, meaning you have to get negative margins with normal surrounding tissue. So in the extremity, I know, at least for surgical residents, they often talk about, surgical trainees that I work with, they often talk about 2-centimeter margins. And that is something that is in some of our textbooks, at least in surgery. But that's actually kind of outdated, and there's really no great evidence to support 2-centimeter margins. What you really need, or what are considered adequate margins when you're doing limb salvage, is negative microscopic margins. And then if feasible, and these are NCCN guideline recommendations, if feasible, if you can get 1 centimeter, it would be good to get 1 centimeter, but basically negative microscopic margins. And what it really depends on are these various factors, such as histologic subtype, anatomic barriers, and adjacent critical structures. What I mean by anatomic barrier and what that image is trying to show is that fascia is important to take for most soft tissue sarcomas. Fascia is a thick fibrous covering over muscle when you're in the extremity, and that even though that may be 1 millimeter in thickness, that's actually considered an adequate margin in most cases. And it really depends on, or we really strive for function preservation, and as mentioned earlier, use of radiation and sometimes systemic therapy to improve outcomes. And this is an example. This is in the trunk. This is in the back. This is a MFH, or as it's now known, undifferentiated pleomorphic sarcoma of the right upper back. And so if we are going to go for margins, just for the non-surgeons in the room, what that really means is 2 centimeters or 1 centimeter away from all visible disease, including the previous scar in this situation. And in the end, that scar ends up being an even bigger scar because sometimes, depending on the part of the body, the reconstruction that you need will make it a bigger incision. But I think the point is, as we talked about with that wine analogy, there are different histologic subtypes. So that margin, the width of the margin, how much you need to get really depends on the histologic subtype. DFSP, myxofibrosarcoma, are 2 subtypes where you do want to get wide margins, and in fact, you may even need wider margins than 2 centimeters. Leiomyosarcoma, another subtype. Desmoid is another subtype. Each of these have different, you think about the disease differently based on the histologic subtype. Okay, so last few slides just about unique considerations in soft tissue sarcoma for the AYA population. And as I mentioned, soft tissue sarcoma, of course, does occur in the AYA population and makes up a significant part of that patient population. So the next few slides I thought I'd focus on, with 1 slide each, about 4 specific subtypes of soft tissue sarcoma that we see commonly in the AYA population. Now, there are, of course, many others, and these aren't the only ones that we see in the AYA population, but these are common ones that we see. So myxoid liposarcoma, this is a cancer of fat, and the idea that these are all supported by distinct molecular genetic aberrations. Myxoid liposarcoma is defined by a FUST DDIT3 translocation. It's most commonly seen in the extremities, but can occur in other parts of the body. Round cell is referring to the histologic appearance, and that's what that asterisk and the figure D there on the right. But round cell refers to high-grade disease. It's more aggressive disease. And when you have a myxoid liposarcoma that has a round cell component to it, it can metastasize. And it uniquely, for this type of sarcoma, actually metastasizes, spreads to atypical sites, and that includes the spine and actually fat-bearing areas. I've always thought this is an interesting liposarcoma in that or an interesting disease in that it's a cancer of fat and actually spreads to other fat-bearing areas. It's exquisitely sensitive, or more, at least I should say, more sensitive to systemic therapy, and it's also very sensitive to radiation therapy compared to other subtypes. In terms of surgical considerations, negative margins are important. And then because of its sensitivity to systemic and radiation therapy, excuse me, oftentimes in patients we do consider multimodality therapy. And then I just wanted to point out among the references, one of them is from, I think he's one of our speakers for the session, a later session. This was a series from MD Anderson looking at liposarcomas in the adolescent and in AYA population. Desmoid fibromatosis or desmoid tumors, these are tumors that are defined by beta-catenin or have beta-catenin expression. That's pathologists commonly look for this by IHC. Desmoid tumors can occur all over the body, although most commonly they do occur in the shoulder pelvis girdle area, the abdominal wall, or the mesentery in the abdomen, the small bowel mesentery. And unique to this disease, again, this drives home the point of the importance of histologic subtype. If you know your tumor is, if you know that the tumor is a desmoid, there's, no chance of distant metastasis. This tumor doesn't metastasize. Having said that, this is a little bit of personal bias, but a lot of physicians do refer to desmoid tumors as benign. If you ask me, if you ask any actual patient that has a desmoid tumor, especially the larger ones, even though it doesn't metastasize, it is still an aggressive disease. I wouldn't consider it benign. I would consider it a malignancy. There are many systemic therapies for desmoid tumors that have been studied and are available. And I think this is a good example of how a combination of research findings translated into actual patient therapies. There are many therapies out there that are being looked at for this disease. Surgical considerations, so also unique to this disease, there is actually evidence, good studies from MD Anderson as well as the Italian sarcoma group and others, that margins are not as important in this histologic subtype. You don't want to leave tumor behind, you don't want to cut into the tumor, but as long as you get the tumor out completely, the outcomes for patients with positive margins and negative margins is actually identical. Now, admittedly, there's more to that than we know, but that is what the data shows. And as I was preparing for this talk, specifically in the AYA population, there is a study from St. Jude's that says that as well, desmoid tumor, the margins in desmoid tumors. And I just wanted to say that these tumors, again, just getting to the point that I don't consider them to be benign. They can be very locally aggressive. This was a desmoid tumor in the small bowel mesentery that I resected from a patient where it was involving the ureter, involving the small bowel, and in order to get it out completely, we did have to resect all those and reconstruct them. And the CT image in the back, by the way, that's an abdominal wall desmoid with that arrow there. And it's kind of illustrating that the tumor may look kind of subtle, but it is actually full thickness involvement of the entire abdominal wall. So that means all of the muscle wall is involved. So that particular patient and other patients like that, we can't just simply cut out a very superficial thing. It actually leaves literally a big hole in the abdominal wall that requires reconstruction. So, and then finally, I think one of the interesting or mysterious things about this disease is that some desmoid tumors apparently do also regress without any treatment. It's a very small percentage, but some tumors do start to shrink on their own for reasons that are unclear to us. So in in our sarcoma societies, there are other institutions that have published extensively about this wait and see policy. Synovial sarcoma is another subtype that is defined by SYT SSX translocation. It occurs mostly in the extremities. It metastasizes to the lungs. And it's also sensitive specifically to ifosfamide in terms of chemotherapy. And we're also finding different molecular markers that can be targeted, such as NY-ESO1. Margins are important in this disease. And then lastly, among the four that I highlighted here in my talk, desmoplastic small round cell tumor is a subtype that we see commonly in the AYA population. And this one is defined by ESWR WT1 translocation. And these tumors tend to occur in the abdomen. They're intra-abdominal, and they also tend to be multifocal, meaning that there's more than one tumor. So the patient has maybe 3 tumors or 4 or sometimes 20 small tumors. Local regional recurrence is the major problem with this disease. It does metastasize, but because of the multifocality, and it's a difficult problem to control regionally, locally. And in fact, the treatment for this disease is cytoreduction surgery and HIPEC. HIPEC is an abbreviation for chemotherapy. It stands for hyperthermic intraperitoneal chemotherapy. But what it really is during surgery, we remove all the disease we can, that's the cytoreduction part, and then we actually we close the abdomen temporarily, just as shown in this figure, and then we actually instill chemotherapy into the patient while the patient's asleep under anesthesia. We circulate the chemotherapy, and the whole idea is that the chemotherapy is trying to get at microscopic or small disease that is probably inevitably present in that patient. So lastly, just I think it was just one or two more slides. In terms of soft tissue sarcoma in the AYA population, I think important issues compared to the adult population are surveillance and patient advocacy. In terms of surveillance for adults, we do have guidelines for soft tissue sarcoma from the NCCN as well as the European Society of Medical Oncology. These aren't strict formal guidelines, but we do have some guidelines. To my knowledge, they're not really strict or good guidelines in the AYA population. Generally speaking, though, we do MRI for the primary site, especially if it's in the extremity, as well as a CT of the chest, or in some situations, chest X-rays to follow distant metastasis for tumors that have high risk of distant metastasis. And it really depends on histologic subtype. And then I will say in the AYA population, I think important considerations or unique considerations are because these are younger patients than the adult population, what kind of endpoint do we do this? What kind of, in terms of surveillance, do we keep on doing this until, it's a lot of years, a lot of additional years to do surveillance. And because of that, I do know in some of my own patients that are in that AYA population, this causes, and also the adult patients, this frequency of surveillance causes a lot of anxiety, or scanxiety, as some of them refer to. And then lastly, patient advocacy, I think, is very important in both adult and the AYA population. I think it is important because it is such a rare disease to see a specialist, whether it's on the surgical side, medical oncology, or radiation oncology. And the AYA population, of course, has unique needs and considerations. And finally, I think there's important research to be done looking specifically at AYA in comparison to the adult population. So I want to thank everybody again for the opportunity to be here to speak about soft tissue sarcoma. And if that is me pursuing the big tumors that I sometimes resect in adults, that's my support team that I wanted to thank. You're at my support team here at USC. If you have any questions, there's my email. I think it is in the program book. I'd be happy to answer any questions. Thank you.
Thank you very much for that very interesting talk. And as Dr. Hu mentioned, we're going to change the format just a little bit. We're going to have both lectures followed by a more extensive question and answer period. So it's with pleasure that I introduce the next speaker, Dr. Omar Ragab, who is Assistant Professor of Clinical Radiation Oncology. Dr. Ragab received his Bachelor of Arts degree from USC and then went on to attend the Keck School of Medicine. From there, he did his residency in radiation oncology here at USC, where he was a chief resident. That would almost qualify him as a lifer at USC, except for the fact that he went over to the dark side and did his fellowship in clinical brachytherapy at UCLA. But he's back. He's back in business here, where he provides clinical services for not only sarcoma, but GI cancers and GYN cancers. And his fellowship was in brachytherapy, and that is his major research interest and clinical interest. So with no further ado, I'll introduce Dr. Ragab, and he'll speak to us, say a few words on radiation.
Thank you, Dr. Menendez and Dr. Hu and Dr. Fryer for inviting me today. We have a pretty mixed audience today, so basically what I was going to try to go over is the basics of radiation, sort of what do we tell patients when they come in to see us, a brief review of irradiation techniques, since that's one of the most common questions, and I think that patients ask as well as other providers might be interested in, and then discuss radiation indications for sarcoma. As with all other tumors, of course, but sarcomas especially, there's a wide variety of sarcomas, from Ewing sarcoma, soft tissue sarcoma, and all of them are treated differently from radiation. So we won't go over all of them, and a lot of it I'm saving for the case presentations, but we'll discuss those. And then a little bit about toxicities, which are going to vary depending on the site of treatment. So how does radiation work is usually the first thing that I talk about when I see a patient in consultation. I think people in general sort of have an idea about chemotherapy. They get some sort of injection, surgery, they get surgery. With radiation, it's kind of this black box that people don't understand. So basically, radiation kills cancer by damaging DNA. It damages the DNA of cancer cells, but also damages the DNA of normal cells as well. So what we do is basically we give the radiation over several treatments, several fractions is what we call them. In sarcoma, for the most part, we're talking about 25 or 30 fractions as sort of a standard-ish dose for radiation. That allows the normal tissue to heal overnight, while the cancer cells, they don't sort of have those DNA repair mechanisms, and they don't use them as well. So they get more and more damage, and then eventually they do die off when they try to replicate. So with the radiation treatment, different cells and organs tolerate the radiation differently. So the side effects will differ depending on the site of radiation. And then the doses of radiation, if they are high enough, cells can be damaged beyond repair. So it is rare, but we can have damage to critical organs such as kidneys, spinal cord, etc. And then finally, that cancer cells, like I said, have a limited ability to repair, and so that's where we get our differential effect. Dr. Tseng, I think, put up a similar study, but basically, for radiation, what we're trying to do is prevent local recurrence. We don't tend to affect sort of the systemic disease, so radiation is definitely a local therapy. In this study, which is sort of one of the landmark studies of radiation, the risk of local recurrence without radiation, you can see, tends to go down over the years, but with radiation, stays high. What they did here, however, is they, in this NCI study, is they censored patients who had metastatic disease from this, so there are some more local recurrences that aren't reflected here. But in general, we do help with local control. Radiation in sarcoma is a wide subject. Many of them are treated similarly, and when we have our case presentations and we have tumor board, I find that I always say 50 gray or 60 gray. I just tend to say the same thing over and over again. It's not because we don't know, it's because that we treat them in general all the same. There aren't specific studies showing for liposarcoma you go to this dose, for an undifferentiated pleomorphic sarcoma you go to this dose. So they sort of get lumped up amongst these types of sarcoma. And we do use them with radiation before or after the surgery to prevent recurrence. So either neoadjuvant radiation or adjuvant radiation. I'll have one slide coming up here on the differences between the two, but essentially they do have the same outcomes. Some sarcomas are treated with radiation for cure. So for instance, a Ewing sarcoma or a rhabdomyosarcoma that can't be resected may get definitive radiation with chemotherapy as their primary treatment. And then some sarcomas have little role for radiation, such as osteosarcoma. So it's difficult to touch on all of them, but you can see that there is sort of a wide range of uses of radiation. Touching on the pre-op versus post-op question, which is usually the most common question that we have at tumor board for radiation. The benefits of pre-op radiation, less long-term fibrosis. The reason for that is that the dose tends to be lower and the area of treatment tends to be smaller. So if we do the radiation before the surgery, we know in the hands of a good surgeon, they're going to resect the biopsy scar, so we don't have to cover that because you can have scar recurrences. Also, our margins, so we put safety margins on our tumors. So for instance, 2 cm or 3 cm over the tumor that we can see. After surgery, there's a lot of tissue damage, there's a lot of inflammation, so it's hard to see sort of the boundaries. If there's a big gross tumor there, you just put 2 cm on that tumor and you're done. But when you have to treat the entire scar and things like that, it tends to get larger. So lower dose, and then you get less skin toxicity with the pre-op radiation because you're not covering the scar as much. The benefits of post-op radiation, however, are that sometimes, and I think this depends on sort of the surgeon's feeling on that case, they say it might make it easier or it might make it harder, depending on sort of the margin status and things like that. There are also less wound healing problems with post-op radiation because the healing has already happened before we give the radiation, and radiation can delay healing. And also, you might be able to avoid radiation in some patients. So when you have the final pathology and you can confirm low grade, high grade, when you just have a biopsy, you might get an overestimate of the state of their disease. One specific example that we're going to talk about in our cases is whole lung radiation. So this is often used in Ewing sarcoma and Wilms tumors, which very often tend to be AYA cancers, where we treat exactly the whole lung. So if a patient who has lung metastases, we give a low dose of radiation to the entire lung after they've completed their chemotherapy in order to prevent recurrence there. This is a hotly debated topic right now in radiation. What's the benefit? Because a lot of these studies happened a long time ago, before good CT scans, before good imaging, so we really don't know what to do with them now. And then lastly, radiation can be used for palliation of symptoms. So a shorter course of radiation, 5 treatments, 10 treatments, sometimes even 1 treatment will help, especially with pain, bleeding, and other complications of a tumor, either at the primary site or even at metastatic sites, such as bone. So I was going to walk you guys through sort of some of the treatment modalities that we have in radiation treatment and sort of what a patient goes through in order to get the radiation treatment. So the first thing they very often have is a CT scan in our department. A lot of people ask, well, I have 15 MRIs, 2 PET scans, and 10 CTs. Why are you doing another one? And so these are special radiation planning CTs. Their bore is wider, which is the hole in the middle here, so it can pass through our immobilization equipment. Also, the CT is calibrated. So the way that the radiation works is based on density. So things like bone absorb radiation higher. Things like muscles and water absorb less radiation. So these are calibrated so that it'll output the correct factors so that we can plan the radiation correctly. The linear accelerator is the workhorse in a radiation therapy department. These machines are sort of versatile. They can be used for things that we're going to discuss, such as 3D conformal radiation therapy, IMRT, SBRT. So all of those buzzwords that people tend to hear are all on one machine. We just use it differently for different sorts of patients. On this, the therapist is positioning one of our immobilization devices, and that goes on the couch, which is where the patient lays down. That can move up and down, in and out, and position the patient appropriately. We can aim radiation with this machine to about 1 millimeter of where we want it to go. So that means that you have to be very precise with your positioning as well. If you're 1 cm off and you're treating 1 millimeter accuracy, then you may have missed the tumor completely. So we very often do daily image guidance to make sure that we're hitting the tumor every single day. So the way this works is basically the radiation shoots out an electron beam that travels down that gantry that you could see. So it's a pretty large machine. It's about 12 feet high. And then the electron beam gets circled around and eventually hits something called an X-ray target, which creates the photons that we actually use to treat patients. So all of these steps have to be verified by a physicist that they're working accurately. So all those things happen behind the scenes. after hours. So it's important. That's why we always say it's important to go somewhere where you can verify that the people are doing things appropriately, because radiation is invisible. You can't see it. You can't touch it. You don't know how much dose you gave unless everything is calibrated perfectly. This is a little GIF of how that works. So basically, you can see that the electron beam turns on. It does like a 270-degree turn, and then finally the photons will come out. And we'll talk a little bit about what they do once they get through all of these apparatuses. So 3D radiation is the most common form of radiation that we give. And basically, on the picture on the left, you can see those are called the MLCs, and they can shape the radiation. So instead of giving like a square or a rectangle, we can shape the radiation. This is all done manually, so either a radiation oncologist or a dosimetrist who works with them will manually create this pattern in order to treat a tumor. So that's called forward planning, and it's one of the most commonly used forms of radiation treatment. So this is an example of a field of radiation treating a pelvis, and basically everything in the red here is blocked, meaning that it's not getting any radiation dose. So those MLCs have closed in that area. Everything in the middle here is getting the full dose of radiation. Same thing on this side. So these are relatively simpler to design. A human can design them pretty easily, and then we can see what dose everything is getting. And the dose distribution sort of looks like this, the one on the left here. So you can see that's sort of like a box that I was presenting before, and this is the dose. Everything in the middle here is getting some dose. As it gets hotter, meaning more radiation, it's more red. So there's some hot spots and some cold spots, and that's expected. And then the one that people ask about the most is IMRT. So IMRT, now, instead of it being a fixed thing, that thing doesn't move, it moves during the treatment. So those MLCs are moving in and out to shape the radiation. So radiation, you can actually sort of bend it around things. So you can bend it around the bowel, you can bend it around the bladder to minimize toxicity. This is not designed by a human can't do this, so it's all computer planned. So it takes a lot of computing power, it takes a lot more time, so it's more expensive. So often we spend time with insurance companies debating the merits of one or the other. So if I believe that a patient needs IMRT, they might say, fine, we'll plan both and send both plans to me, and we'll decide. So those are some of the other things that are happening behind the scenes. And finally, SBRT, or rapid arc. So that's the sort of newest kid on the block for radiation. And basically what we do is we take those 25 or 30 treatments of radiation and we condense them down to one treatment, or 3 treatments, or 5 treatments. So it's very, very high dose radiation, and it's very intensely modulated. So those MLCs are moving very quickly to deliver the dose appropriately. You can also now deliver the dose while this is moving. So it'll deliver the radiation instead of over 30 minutes or 15 minutes, you can condense that treatment down to 2 minutes. So it's another way to make things faster because the patient has to hold still for 15 or 20 or 30 minutes, which is very difficult, especially if you're sort of in an awkward position or you have some post-op pain, all these other things that we have to think about. So the more advanced the technology, hopefully the faster we can treat. I'll touch on this briefly, but basically when you're aiming the radiation so precisely, if you're treating like a lung tumor, that's moving up and down and in and out as the patient breathes. So you have to have ways to track that. So that's something called respiratory gating. So either the patient can hold their breath during the treatment, or we can watch the tumor move during the treatment and only treat when it's within what we're aiming at. People often ask about proton therapy. So proton therapy, the benefit of it is the following. So this is a standard X-ray that we use. So all of the things that we talked about, 3D, IMRT, SBRT, they use photons. So the photon, as it goes in, delivers more and more dose, and then it sort of lags as it comes out. So you can see all of this dose isn't really doing anything because the target is in this area. With protons, the dose sort of goes up. You still have entrance dose, but once it hits a certain depth, it drops all of that energy right in that little area. So you can basically give the radiation while sparing everything behind that, which is very beneficial, especially in pediatrics. This is what a proton center looks like. So they have these huge synchrotrons that create the protons, and it feeds it into multiple vaults. Because these are so expensive to run, you want them to run basically 100% of the time. So while you're positioning one patient, you can be treating the next patient, and you kind of keep moving back and forth. These are huge machines, so if you imagine a person, they're probably going to be only in this, like the height of about this green area, so they're huge and they take up a lot of real estate, and they're very expensive to build, so there's not that many of them. And so basically with a proton beam, it's sort of creating the tumor, it's shaping the radiation to match the tumor anatomy. So it's the most precise method, but also then the most expensive, which then leads us back to sort of the questions of, who do we want to use this limited resources on? And so this is what it looks like. So 3D radiation, you deliver the radiation sort of with multiple fields, and you try to get it hot in the middle. With the IMRT, you have more shaping of that, and you can use multiple different angles. And then with protons, you can avoid all of that exit dose. An example of somewhere where that might be important is in a small child. So we might have to treat something called craniospinal irradiation, where you treat basically the brain and all of the fluid lining the spinal cord. So the radiation up front here, this green, is in a high dose, but it's sort of showering all their organs with radiation. So they have growth abnormalities, things like that. With protons, you can avoid that, so that's a huge benefit for pediatric patients. So somebody who might need that would be sent to a proton center. We also have something called gamma knife, which treats brain tumors. And basically, it's a way of delivering the radiation while avoiding treating as much of the brain as possible. So it's sort of the most conformal technique that we have for the radiation treatments. One quick pass-through of treatment planning. So there's a radiation oncologist, and there's a big team that I'll sort of go over. But basically, each patient has an individual plan. You can't use one plan for another. Everybody's anatomy is different. Everybody's toxicities will be different. So each patient has an individual plan. And we have different software and different techniques for each modality and different organ constraints for each modality. The radiation oncologist will do something called contouring, which is basically just drawing. So we draw the organs and we label what we want to treat. So for instance, this is a prostate cancer. And so we contour out the prostate and we say we want to give the prostate X dose, but we want to give the bladder, the rectum, and the femoral heads Y dose to avoid toxicity as much as possible. We might use other images to help us. So this is a PET scan, so tumors light up very often on PET scan, or MRI, which gives good contrast. And so that might help you draw out your lung cancer when there's all this atelectasis or lung collapse because of the tumor. You don't want to treat that with radiation. That's just going to add toxicity for no reason. So use something like a PET scan to help you delineate the tumor much better. After the radiation oncologist does that, there's a dosimetrist who actually comes up with the radiation plan. So basically, they will design the radiation to treat what we want to treat and avoid it where we don't want any dose. And we'll look at something called the DVH, which gives us all of the organ doses, the mins, the max, the means, and we look at all of this to help determine if this is safe. And there's national guidelines on sort of what are safe doses for most organs. And finally, this is sort of an axial view of a plan, and it sort of goes over all of the anatomy so we can view the radiation plan and make sure that it's safe and is treating the entire tumor. This is a large retroperitoneal sarcoma, Dr. Tseng's special. So we treat these with about 50 gray of radiation. Thankfully, they move the bowel out of the way when they grow, so we can treat them with radiation. But the efficacy of this is sort of unknown at this point, and there's still debate on whether or not this is beneficial. And like I said, there's a lot happening behind the scenes. So the patient will probably meet the radiation oncologist. They won't meet the physicist who's responsible for the machines, so they're a critical component of the team, the dosimetrist who designs the radiation, but they will see the radiation therapist who actually delivers the radiation, as well as the nurses who help the physicians care for the patients in the clinic. So these are sort of some of the modalities that we use to verify that the radiation is safe. So we basically treat a phantom, which we deliver the patient's radiation plan, and we compare what we expect it to look like to what it actually looks like. So that way we can verify on a patient individual basis that this plan actually delivers what we think it's going to deliver, because once again, we can't see it, so we have to verify all of these things before we get started. Also, they will check the machines daily, monthly, and annually in varying levels in order to determine that they deliver what they say we're going to deliver. So the physician sort of oversees all of these things to make sure that the treatment is safe. And one last word on toxicity. Unfortunately, we won't be able to go over all of the toxicity because it's very site dependent. So for something like head and neck cancer or prostate cancer, the prostate is always in the same place. So you can sort of say, in general, you're going to have some bowel toxicity, some bladder toxicity, etc. With sarcomas, they really do come head to toe. And because this is a local therapy, the side effects will depend really on where is this tumor and to what dose am I treating, as well as previous treatments. So with re-irradiation, you can have more toxicity than the first go-around. The body actually sort of remembers what radiation dose it got, so the toxicity can come back much quicker, and you might have a lot more toxicity, actually. So these are the sort of toxicities in a long form that we can expect with radiation. Not every patient will have every one of these toxicities, but they do differ. The most common one that we talk about is skin toxicity. So this is an expected expected toxicity of radiation, and the most commonly encountered one was sarcoma. So usually we'll send patients to wound care if needed. Our nurses are trained in wound care for radiation, so we do try to manage it in our clinic as best as possible. What I do tell patients, though, is there's nothing we can do to prevent the toxicity. All we can do is try to help it, help you feel better until it just heals up on its own. Hair loss is one of the most common things. Usually we don't actually get hair loss from radiation unless we're radiating the scalp. So a lot of patients do feel that is something obviously that's important. So thankfully we can say that, unlike some of the chemotherapies that we give. So in conclusion, surgery is the primary treatment modality for the vast majority of sarcomas, and radiation is used in concert with that to prevent local recurrences. Radiation can be used to improve local control. There are multiple radiation techniques that we can use, and many of these tumors are treated differently and should ideally be managed in a multidisciplinary setting with experienced surgeons, medical oncologists, and radiation oncologists. Thank you very much.
I'm going to ask Dr. Tseng to come up, and there'll be a quick question and answer session. But in the meantime, I just want to say a few words about limb salvage and amputation. And there's been quite intense effort over the years to develop limb-sparing techniques. But not every patient is a candidate for limb salvage. And I just want to make the point that amputation is not a bad thing. In the American Civil War, it took surgeons 90 seconds to do an amputation of the lower extremity. If it took them longer, the patient would die. 50% of the patients died in the immediate postoperative period after that amputation. So amputation got a bad rap. If they survived, they'd either get a peg leg like Captain Bligh, or no leg and just crutches. So having an amputation years ago wasn't a very good thing. But there have been unbelievable advances made in prosthetic management, which we haven't talked about here today. And it's been amazing, you know, with the research, especially that's gone in the last 20, 25 years with the wars in the Middle East and so forth. Patients with amputations function very, very well. And sometimes it's very difficult. One of the most difficult things for me sometimes is to convince a patient that they need an amputation, because they're so convinced that we can cure everything with limb salvage. And that's just not the case. But as I said, the prosthetic management now is nowhere near what it was 50 years ago. So with that, I'll open up to any questions anyone has for the speakers. Yes?
Can a patient become diabetic after radiation therapy? Or,
So in general, patients don't get diabetes after radiation. The pancreas is actually very resistant to radiation, so it does continue to function after the treatments.
So diabetes? Sorry.
Not that I'm aware of. Depends on the type of tumor. So maybe if they have pancreatic cancer or something where they've removed a significant portion of it and there's not a lot left, that's something maybe that would be possible. But like I said, in general, it's not something that we expect.
Or osteoporosis, like your early osteoporosis, if even they're young? No?
In general, no, it's not
No,
something.
okay, okay, thank you.
So, Will, I want to push you a little bit specifically on desmoid tumors because I know we have a lot of practicing oncologists in the audience, and I think we're at a real inflection point, and you briefly touched on it. But as you know as well as I do, in Europe, they almost never do surgery anymore for desmoid tumors. It's a real difference between Europe and North America. And it's partly because, as you mentioned, and I touched on it briefly as well, these don't metastasize. They're really a problem of pain control and function. And they do often, we can't predict their progression. And it was a big problem managing them. We have some effective therapy, as I mentioned now, probably at least 2. One's already been approved or at least published, and probably the gamma secretase inhibitor will get approved as well. And so I just think we should be cautious about, the field is moving, and we should be cautious about if you see a patient with a desmoid tumor, it really should go to a center because it's being treated much differently now than it was 10 years ago because what we have available and what we've learned, which is surgery can often lead to more problems. And so I'm just curious if you agree with that, because I do know it's had less of a chance to move to North America, but my sense is we are tending to agree more with our European colleagues on this.
Yeah, no, I think it's a great point, and from a research standpoint, I think we need to further define those, or at least have a way to define that subset of patients where that wait and see policy is relevant. It's clearly not, one desmoid isn't the same as the other desmoid. They're clearly probably subsets. We just haven't really defined them. There is some work, as you know, with 45S, 45F mutations. There are differences, but we still need to work on that. From a management standpoint, I will say that, as you pointed out, most of that literature and most of those studies about wait and see and tumor spontaneous regression comes from Europe. There is one study from the Toronto group as well. There's not as much here in the United States, and I don't know if that speaks to the fact that maybe there are differences between European patients and American patients. I don't know if that's it, if it's lifestyle or what it is. We don't have a good handle for it. I will say that this wait and see policy, when I do this in my own patients with desmoid tumor, and this is after a lot of counseling about pros and cons, what happens if the tumor does grow while we're waiting and seeing. Most, in my experience, and anecdotally in the experience of other sarcoma surgeons around the United States, we don't seem to see as good results. But that hasn't been formally studied at this point. But it does get to the idea that it is important to see someone who specializes and knows about desmoid tumors to be able to kind of weigh the pros and cons of wait and see versus if it progresses, do we do surgery, do we not do surgery, do we add other modalities, do we try a systemic therapy? It is a very complex disease and on many levels.
Yes, sir. Yes.
You're dealing with a very young population, and I'm wondering what sort of reproductive protections are offered to patients. Whether there's any risk of protecting reproduction or not.
It depends on the area that we're treating. So usually we talk about reproductive issues when we're treating the pelvis, the male pelvis or the female pelvis. We always have that discussion with any patient of reproductive age. In general, we can't spare the reproductive organs. If they need to be treated, they need to be treated. So we talk about things like egg preservation or sperm banking with patients to maintain their fertility after treatment. So those are discussions that are always had with a patient. For patients in the younger side of the AYA spectrum, they tend to pursue it. It's almost never covered by insurance, so it tends to be an out-of-pocket thing, which can make it cost-prohibitive for people. And then patients on the older side of the AY spectrum very often say it's not really a concern for them, but it is important to have that discussion before any systemic or radiation treatments are given.
Yes?
Now that IMRT and SBRT are becoming more and more precise, where do you see proton therapy fitting into that, and what kind of patient would you recommend, even though we don't have too many centers in the area, actually pursue proton therapy?
So very often we use it for pediatric patients for things that require craniospinal irradiation, like the example that I showed. We also use it in other types of things where we need to give a high dose of radiation therapy. Sometimes we go to like 50, 60, 70 gray for things like chordomas and things like that. So it's very, very patient specific. Oftentimes the patients who get protons come in asking about protons. And they sort of say, I read about this, I'm interested, can I get a consultation? Most often that discussion happens at CHLA, more so than here. How it's moving forward is very difficult. So proton centers have been having trouble staying open very often because they're so expensive, insurance companies don't want to pay for them. And it's hard to keep a proton center open that's only treating like a handful of pediatric cases who really need it. So a lot of people say, well, you need to treat the prostates and the other things that don't necessarily need radiation so that you can keep these places open. So I think it's something that is going to have to be discussed from, unfortunately, a healthcare economics perspective rather than a patient perspective. But in general, major metropolitan centers tend to have one or two in the case of the Southern California area. So we can send patients who need it there, but is every patient going to get protons in the future? I don't think so, because the other modalities have gotten so good at replicating that dose pattern, but we never know where medicine is moving forward.
We have time for one more question. Yes, sir.
What about long-term screening and effects for late effects and risk of second cancers or heart conditions? I mean, is that getting locked in now for patients to be screened earlier than they might be?
Yes, especially in our pediatric population. So CHLA has like a survivorship clinic where they do continue to monitor patients. Eventually they grow out of the children's hospital setting, so they need to mature into another follow-up. So I think that might be a great role for the AYA, where we can take patients, because they're watched so closely when they're children, we have excellent records and we can transition them to be monitored. Oftentimes you only see your oncologist for maybe 5 years after the treatment. So then the second thing becomes, do we need survivorship clinics or better education of our primary care physicians who really do have that lifelong relationship with patients that is just often difficult for us to maintain. People say, I'm 5 years out, do I really need to keep coming back to see my surgeon, my med onc, my rad onc? It's a lot of time, and it's a lot of money, and it's a lot of scans. So I think that's something that we're still grappling with as a medical community. But I do think, especially for AYAs, this is a population where we can try to address it as a group.
Okay, thank you.
May I just take 1 second? Thanks, Omar, for that really great response. I did want to point out, actually, that we do have a survivorship program at CHLA, as you mentioned, where we follow patients through 21 years of age. But actually, for a few years now, we have a survivorship clinic here at the Norris for patients who are 21 and older. So if they're higher risk, including those who have received radiation, they transition over here and are followed then annually in our survivorship clinic. More recently, actually, we did launch in 2017 a survivorship program for adults treated here at USC Norris as well, which is focused on our patients treated up to the age of 50, so that would include all of the AYA patients. Dr. Ha is going to be presenting some information about survivorship care for these AYA patients who have been treated for sarcoma. But thank you very much. Great presentations.